Rapid-fire clinical vignettes, urology, gynecology, and trauma review. Let's jump straight into question 1.
A female patient presents with day and night urinary incontinence a few weeks after a difficult hysterectomy operation. Now, on her urodynamic studies, she actually exhibits a completely normal voiding pattern. So, which of the following is the most likely cause of her symptoms? Is it A, vesicovaginal fistula, B, uterovaginal fistula, C, stress incontinence, D, urethrovaginal fistula, or E, enterovaginal fistula? The correct answer is A, vesicovaginal fistula.
Let's break down why. A vesicovaginal fistula, or VVF for short, is the most common acquired fistula of the urinary tract. In fact, a massive 60 to 75% of these cases happen as an iatrogenic injury during hysterectomies for benign conditions. It classically pops up about 1 to 3 weeks post-op as this constant, continuous day and night urinary drainage. But here's the really crucial part to understand. Because the structural integrity of the bladder neck and urethra isn't damaged, these patients can still maintain a totally normal voiding pattern on urodynamics, even with that continuous leakage happening in the background. Now, for your exam pearl, you've got to remember the 3-swab or double dye test. If you put methylene blue into the bladder and have the patient swallow oral phenazopridine, which turns the urine orange, you can perfectly pinpoint the fistula. Blue dye on the lower or mid-vaginal packing, that's a vesicovaginal fistula. But if you see orange dye strictly at the top of the packing, you're looking at a uterovaginal fistula.
Moving right along to question 2, a multiparous female, meaning she's had a few kids, presents complaining of urinary leakage that happens specifically when she's weightlifting. She hasn't sought any prior treatment, and the issue has just gotten worse over the past year. What's the best initial management strategy to advise here? A, mid-urethral sling, B, pelvic floor muscle training, C, Birch Culpa suspension, D, intermittent self-catheterization, or E, oral oxybutynin. The correct answer is B, pelvic floor muscle training.
Let's look at the why. With stress urinary incontinence, or SUI, you get involuntary urinary leakage right when intra-abdominal pressure spikes, so things like coughing, laughing, or like our patient, lifting heavy weights. In a multiparous female, this presentation is basically textbook for SUI. All those repeated vaginal deliveries physically weaken and disrupt the pelvic floor muscles and fascial supports, which ultimately leads to hypermobility of the bladder neck. So here is your absolute first-line rule. You must always maximize conservative pelvic floor rehab first. We're talking structured Kegel exercises for 8 to 12 weeks before you even think about putting them on an operating table. Only if that conservative therapy fails do we escalate to the minimally invasive gold standard, which is a mid-urethral sling.
Question 3. What is the best initial interventional treatment option for a male patient experiencing severe, persistent stress urinary incontinence after a radical prostatectomy? The options are A, artificial urinary sphincter, B, male sling operation, C, suprapubic catheterization, D, long-term Foley, or E, oral oxybutynin. The correct answer is B, male sling operation.
Here's the deal with stress urinary incontinence in men. It's almost always an iatrogenic complication. It usually comes from direct trauma to the external urethral sphincter during a radical prostatectomy or a TURP procedure. Now, for mild to moderate post-prostatectomy incontinence, a male sling operation is an absolutely fantastic, minimally invasive option. It provides reliable compression right under the bulbar urethra to restore continence. The big takeaway for you here is understanding the difference in indications. Slings are perfect for mild to moderate cases because they don't require any manual dexterity from the patient. On the flip side, the artificial urinary sphincter, or AUS, is the ultimate gold standard for severe total sphincter incontinence. But the patient absolutely has to have the physical ability to manually pump a scrotal control valve to use it.
Question 4. We have a 25-year-old female presenting with burning micturition, increased urinary frequency, lower abdominal pain, and an intermittent low-grade fever. On examination, she has significant suprapubic tenderness, and her urine labs show numerous pyura cells. What's the diagnosis? A, acute glomerulonephritis, B, acute cholecystitis, C, isolated urethritis, D, acute cystitis, or E, none of the above. The correct answer is D, acute cystitis.
This one is a classic. That clinical constellation of frequency, urgency, dysuria, suprapubic discomfort, and pyuria, that is the textbook presentation of acute cystitis, which is a lower urinary tract infection. Because females have a shorter urethra that sits really close to the vestibule, lower UTIs are incredibly common in young, sexually active women.
Your major exam pearl here is all about differentiating the anatomy. Cystitis, a lower UTI, stays highly localized. Think dysuria, frequency, urgency, and pain right above the pubic bone. Pyelonephritis, which is an upper UTI, systemicizes. That's when you start seeing high fevers, shaking chills, nausea, vomiting, and really specific flank or costovertebral angle tenderness.
Question 5. A 50-year-old woman comes to the ED complaining of upper abdominal pain. Her abdominal ultrasound shows a completely normal, thin-walled gallbladder filled with fluid, but they incidentally spot a solid mass in her left kidney. What investigation should be ordered next? A. HIDA-scan. B. IVP. C. Contrast-enhanced CT scan of the abdomen and pelvis. D. Oral cholecystogram. Or E. Upper GI series. The correct answer is C. Contrast-enhanced CT scan of the abdomen and pelvis.
So, her ultrasound findings for the gallbladder are totally normal. They don't explain her pain at all. But we definitely can't just ignore that incidental solid renal mass. It needs immediate, high-resolution evaluation. This brings us to a huge exam pearl, the solid renal mass protocol. Any solid renal mass discovered on a screening ultrasound has to be evaluated using a triphasic or multiphasic contrast CT to check for renal cell carcinoma, or RCC. This is the absolute diagnostic gold standard. It tells us the vascularity of the mass, since malignant RCCs light up with intense contrast enhancement. It maps out local infiltration, and it screens for regional lymph nodes or tumor thrombi. And remember, we generally avoid doing a biopsy because of the high risk of tracking tumor cells along the needle path and the mass being so highly vascular, unless, of course, we strongly suspect metastatic disease.
Question 6. A 41-year-old male suffers blunt torso trauma after an accident with a tractor. On exam, he's got generalized abdominal tenderness, and you suspect an intra-abdominal visceral injury. The urinary bladder is not palpable. A retrograde cystourethrogram shows contrast leaking directly into the peritoneal cavity. What's your surgical plan? A. Staging with elective laparotomy. B. Midline laparotomy with formal intraperitoneal bladder repair. C. Percutaneous cystostomy. D. Long-term Foley. Or E. Observation. The correct answer is B. Midline laparotomy with formal intraperitoneal bladder repair.
Let's unpack this one. Seeing contrast extravasating right into the peritoneal cavity perfectly confirms an intraperitoneal bladder injury, which is usually a big tear right at the dome of the bladder. Urine spilling into the peritoneal cavity causes a severe chemical peritonitis and massive metabolic derangements, so this is an absolute emergency. It mandates an immediate exploratory laparotomy, direct surgical closure of the bladder wall, and copious washing out of the peritoneum. The bladder rupture dichotomy is incredibly high yield for exams. If it's an intraperitoneal rupture, the dome is torn, urine is in the belly, and you're going straight to the OR. But if it's an extraperitoneal rupture, you're usually dealing with a fracture at the base or neck where urine leaks into the pelvic space. That type, you manage it conservatively with simple Foley catheter drainage for about 7 to 10 days.
Question 7. What is the most appropriate initial diagnostic investigation for suspected extraperitoneal bladder injury following blunt pelvic trauma? A. Retrograde cystography. B. Transabdominal ultrasound. C. Non-contrast CT. D. IVP or E. Urinalysis. The correct answer is A. Retrograde cystography.
Retrograde cystography is hands down the gold standard imaging modality for diagnosing both intra- and extraperitoneal bladder ruptures. But the key detail you need to remember here is execution. You have to retrogradely instill at least 400 milliliters of water-soluble contrast to fully stretch out that bladder parenchyma. High-volume distension is literally non-negotiable. If you don't use enough volume, you can easily miss a small leak on a standard scan. And that brings us to the cystography execution exam pearl. A proper plain film cystography requires a minimum of 3 distinct views. You absolutely need a baseline scout film, a fully distended film, and crucially, a post-drainage film. That last one is vital to catch any posterior extravasation that might just be hiding behind a bladder that's full of contrast.
Question 8. A patient rolls into the ED after a severe motor vehicle collision. He has a confirmed pelvic ring fracture and you suspect a bladder injury. Which investigation definitively confirms or rules out a bladder injury? A. Intravenous cystography. B. CTKUB. C. Play and pelvic x-rays. D. Pelvic MRI. Or E. Retrograde cystography. The correct answer is E. Retrograde cystography.
Pelvic fractures, especially those anterior arch or open book pubic gramide disruptions, have a massive association with extraperitoneal bladder lacerations. Basically, the bladder gets sheared right open by sharp bony spicules from the fracture. Standard non-contrast CT scans, or IVPs, simply do not distend the bladder enough to force out visible contrast, which is exactly why you have to use a retrograde cystogram. But before you even get there, here is a life-saving exam pearl: the blood at the meatus rule. If someone has pelvic trauma and you see gross hematuria or blood at the urethral meatus, stop right there. You must perform a retrograde urethrogram, or RUG, before you even think about inserting a Foley catheter, just to definitively rule out an associated urethral transection.
Question 9. What is the most likely cause of acute urinary retention in an otherwise healthy 30-year-old female patient? A. Clot retention. B. Urethral stricture. C. Fecal impaction. D. Acute urethritis. Or E. Retroverted gravid uterus. The correct answer is E. Retroverted gravid uterus.
Now, we usually think of acute urinary retention as a male issue caused by a large prostate, but it absolutely happens in young, perfectly healthy females, and a retroverted gravid uterus is a prime suspect. As a pregnant uterus naturally enlarges right around that 12th to 14th week of gestation, a retroverted uterus can get physically incarcerated underneath the sacral promontory. As it grows and elongates, it literally pulls and compresses the bladder neck and proximal urethra right up against the pubic symphysis, creating a hard mechanical obstruction. Your key takeaway here: always keep the other high-yield female retention causes in the back of your mind too. Things like severe pelvic organ prolapse, massive fecal impaction compressing the urethra, or that tricky psychogenic retention we call Fowler syndrome.
Question 10. What is the best modality to definitively confirm whether a bladder tumor has actually invaded the detrusor muscle layer? A. Diagnostic cystoscopy. B. Pelvic MRI. C. Bimanual exam under anesthesia. D. IVU. Or E. Turbot with separate base biopsy. The correct answer is E. Turbot with separate base biopsy.
Look, while you can easily see a mass during a visual cystoscopy, it is totally impossible to determine the microscopic depth of that tumor's invasion just by looking at it. To definitively confirm if it has reached the detrusor muscle, you need a turbeat. The surgeon has to go in, resect the exophytic tumor mass, and then, critically, take a separate, much deeper biopsy right at the underlying tumor base. You need to capture those detrusor muscle fibers for the pathologist to review. This right here is your staging lifeline. Finding out whether there is detrusor muscle invasion is the single most critical checkpoint in all of bladder cancer management. It completely separates superficial non-muscle invasive disease from highly aggressive muscle invasive disease, which entirely changes the treatment paradigm for the patient.